Hey everyone. I'm so glad you're here, and I'm really excited to have Jill Mueller, who is a pelvic health physio from Ontario. And she's going to help me dive into a topic that has so many question marks floating around it: endometriosis. I treat many women in the clinic with endometriosis, and I do know that I have a lot to offer, but I've never felt endometriosis. I've never lived with it. And I know there's a lot to be said about that. So enter Jill. I met Jill in a course a few years ago, and what I really loved about her story is that not only has she lived with endo and she has a story about it, but she also is a very accomplished pelvic health physio who treats women with this all the time. And what stood out to me about her is that she was obviously really passionate about this area. And instead of this big dark cloud hanging over endo, which I feel like a big dark cloud and heaviness I feel is associated with endometriosis, but I feel like she does such a good job of like lifting that and saying, well, no, wait, these are things that you can do and it doesn't have to be all negative. So that's why I wanted her here today, so that I feel like she could better answer a lot of the questions that I'm being asked. And so Jill, thanks for being here. I would love for you to yeah, I would love for you to tell people a little bit about yourself and kind of like what brings you to this area and what kind of clients you treat.
Well, I actually originally went into pelvic health because of my own story, my struggles with endometriosis, my 10-year journey with fertility issues, partly because of it. And I thought, you know what, like I have too much passion to help people with this that I can't not look into it more and see what I can have to offer. And that's really what brought me to it. I was already using visceral therapy, which is a form of like osteopathy to help women. And I really took pelvic health to give me more street cred. But there's so much information that I've learned diving into this, and I absolutely love it, just like you said. I see a variety of patients. I originally wanted to treat women with mechanical fertility issues. Physiotherapists can't really treat fertility per se, but using visceral techniques and lifestyle changes and health education, that I think we do have a lot to offer that we should be offering. But from there, a lot of men started coming through my door because there are not a lot of other pelvic physios in the area that treat men. And so I was like, okay, they're great to treat. So I treat men, I treat all ages of women. I'm not really into peds, but I have to say probably pelvic pain is my passion, and endometriosis for sure fits in that category.
And I love having you as a resource. I would say that that's something, if I'm ever questioning something in that, because we all tend to draw a certain caseload more than anything. Do you know what I mean? We see all areas, but we tend to, I find, hone in on one thing. And I've started to see a lot of pregnant and postpartum women. That's who I draw the most. And so when it's something out of the ordinary with the pain, I always think of you. So I love it. I have so many questions. And obviously we'll get into the details of endometriosis, treatment ideas, how we can help. But I want to start at the very beginning. And I would love for you to start with talking about just why someone would think they might have endometriosis, or what symptoms they would first feel.
Okay. It's a good question because people will sit on the other side of this camera and think, I know the answer to that. It's menstrual pain, but it can be multi complex. That gets obvious when you go through puberty and you get your period, but endometriosis has been found in fetuses. It's been found in men. So a lot of the conceptions of what it is and how it became is kind of starting to be swept aside, and we're realizing this is a lot more complex than we originally thought, that it was just menstrual cramps. So that's the obvious one. But with children so premenstrual, they get usually it's a lot of constipation, digestive issues, which is complex because that can be anxiety related. It's hard to tell if that's endometriosis related or not, but you have to look at maybe the past history of the mothers involved, like the mom or the grandmother. Did they have trouble? They may not know if they have endometriosis, but did they have menstrual cramps? Did they have any trouble getting pregnant? So those are little clues before you hit puberty. And then when you hit puberty, the menstrual pain is probably the most prevalent one. 70% of the time when a girl has menstrual pain, it is related to endometriosis. So I don't think we can say that menstrual pain is normal.
Mm-hmm.
Like that's a high stat.
Mm-hmm.
Along with that, more prevalent in adolescence is non-cyclical pain. So maybe digestive discomfort, abdominal pains, different symptoms related to pain. They could have, and then as we get older, it could get a little more complex. So bowels can be involved, the bladder, we can get bladder pain syndrome, pain with having to urinate, or pain when our bladder is quite distended, and we'll probably get into why with that, but bladder, bowel, digestive, and menstrual cramps are the biggest ones.
Okay. And when people, I mean, usually women, we're mostly going to be talking to women in this, but when people experience this, what tends to happen? I would like you to talk about what do women do? Obviously, they're going to go to their family doctor. Probably they'll live with it for a long time and not be able to figure out what's going on, but eventually they'll go, I'm sure, to their family doctor. So I would love for you to talk a little bit about that. Once they go to their family doctor, what kind of chain of events does that usually set off?
This is where it gets frustrating,
Mm-hmm.
because I think the family doctors need to be more educated on how to screen for this. They don't need to do like they need to be more aware of the other symptoms and listen to the whole story, or ask probing questions about digestion and what were you like as a kid, were you constipated? Like, they need to know what questions to ask to figure out if there's a higher risk of them having endometriosis, because then it's, oh my gosh, it's everything in being able to streamline their treatment protocol. A lot of times, and I just saw somebody like this, this girl that just finished first year university. As soon as she moved out of the house, her symptoms magnified. So yes, she had constipation, years of constipation, digestive issues, menstrual pain. Like, she checked all the boxes. And what that does is it makes our system more sensitized. We call it central sensitization, but what that means in the layperson's terms is, like, it's an autoimmune disease. We tend to get more sensitive to things, like everything, sometimes noise, sometimes light, sometimes smells. And it's a slippery slope. You add in more stress, like first year university, and it can be quite debilitating. So she had been to GI specialists. She had been to urologist because of her bladder pain syndrome. She had been to so many gynecologists, everybody that was not saying potentially you have endometriosis. And so really what I would love to see is the right questions from the GP, and then a referral right away. They don't need to do surgery or anything, but to an endometriosis specialist.
Mm-hmm.
And that way they can be monitored and directed under their care. It can make all the difference, but that's not what's happening. The average time of being diagnosed is like 7 to 12 years.
Exactly. And I'm going to get into that a little bit more, but I feel like I should back up for a bit and ask you to explain what exactly happens. Why are women even experiencing these symptoms? Like, what is going on in the body that's giving the pain?
Yeah. So endometriosis is it's an estrogen dominant and estrogen dependent. So estrogen dominant means that there's going to be more estrogen. When there's more estrogen in the body, it can give you digestive problems, bloating and stuff like that. But those are issues that can happen with other things. So you have to put the whole picture together, right? it also means that when they go on the pill, they might feel better, but just knowing that's a band-aid solution. It is not stopping or slowing the endometriosis. It's just diminishing the symptoms of it, which is a thing. That's fair. Um, and that's a good option for teens, to be honest. Um, it's an autoimmune disease. So what that means is our body is constantly sort of fighting on high alert.
Yeah.
How would you describe it?
When you were saying fight, I was going to say fighting itself. Like
Fighting itself, like a little bit. I don't want to make it sound
no,
catastrophizing
but
because there's a lot of
it's not
things we can do.
it's not working. You know, yeah, it's kind of working against itself. Or
Yeah, it's chugging along,
yeah,
doing too much work. It's not efficient. And there's a lot of lifestyle things we can do, which we'll get into, that can be helpful for that, which the
yeah,
doctors never talk about. But so it's constantly, yeah, it's so really what they don't know exactly. They used to say it was retrograde flow out of the uterus down the fallopian tubes, but they know that's not the case now because it's found in fetuses, it's found in men occasionally. Occasionally it'll be found in the nasal septum or up around the heart or in the lungs. Like it's not even anywhere in the abdominal area. So they don't know exactly. They do know for sure. They've done studies where there was a dioxin, which is a byproduct of an herbicide that used to be used a lot. I think it might be banned now, at least in Canada it's banned, I think. Don't quote me on that. But there was research to show when they gave it to monkeys, they developed endometriosis. So that is in our environment, right? So there's environmental factors, there's genetic factors, they know that. And it's worldwide, and does not discriminate with race or anything like that. So they still don't know a whole lot.
And Jill, describe, like, because we talk a lot about lesions with endometriosis. So can you explain like what does that look like in someone? Because I find that I'm always trying to just give them a little bit of a picture of what that looks like in their body compared to quote unquote normal. Yeah.
Yeah. So in the medical world, we call it lesions. I hate that word because
It's such a negative word. And I
sounds so
love
horrible,
that
right?
you're always like, stop using the negative.
Yeah. So language wise, I try and just say endometrial tissue because it sounds way
Yes,
softer.
it does. Sounds nicer.
But basically it's like a little bit like a spider web, or can cause adhesions between different organs or in the fascia. It tends to pocket between the bladder and the uterus, or the uterus and the rectum, which is why we have bladder or rectal symptoms in most cases. Sometimes it's around the ovaries, so the women might get pain during ovulation as well. So this tissue, though, they say when they learn it in medical school and gynecology school, they learn to look for brown or black lesions, spots. And I guess somebody put up a slide, 25 different slides of endometriosis lesions. Sorry, I keep saying that word, but
Well, that's okay.
talk medically.
Yeah.
and they asked the doctors. This was at the International Pelvic Pain Society. There's a lot of doctors there and physios and stuff, but which ones were the endometriosis, and they would put up their hands, but it was always only on the black or the brown ones, and it does not look the same apparently when it's younger. So in someone who is younger, it might be red, it might be clear. And that is a problem if you get a gynecologist who's doing exploratory surgery and they don't know what to look for. So it really comes down to having to find the right specialist too. But basically adhesions.
Okay.
In the viscera.
Yeah, I kind of picture, like, I love the visual of spider webs too. I often use that visual, and then I tell them to almost picture that it's like a jammed up spider web. Like I picture that it's not like nice and open, but it's kind of like this, and that nothing's happy around there because the blood supply isn't as good, the nerve supply isn't as good, the lymphatic system can't flow through there as well, and so it just makes it kind of like a sticky.
And it feels, you can feel it tugging sometimes when you get into certain
Exactly. Because when we move, like everything, like the whole spider web moves, like our
Yeah.
spine moves, our ribs move, our organs move. And if anything's sticky, it's going to make that area feel stuck, right?
Mhm.
You led nicely into my next question, and because we touched on it earlier, and you talked about a specialist. I would say, I'm guessing what you mean by this is that there's different people that can specialize in this, and I think a lot of people assume that's only a gynecologist. But can you talk about that a little bit more? Like, what does a specialist mean? Yeah.
So there are a lot of it's generally gynecologists or urogynecologists that might be going on and taking sort of specializing in endometriosis. But a lot of times, I'm probably going to lead into another question of yours, but a lot of times the gynecologist or the urogynecologist will take like ablation therapy courses, which means that you are using a laser or something to cut off the surface of where the endometriosis is, but it is only the surface. Endometriosis can be like a iceberg. So it can go deep, and you really need to be able to, it'll just grow back in that spot. So you need to be able to cut it out or excise it, excision therapy, which then takes more training. And I guess so in Canada, it's different, but from where I've read my resources in the States, when they put in their code for the therapy, like for excision or ablation, they get paid the same amount. So the problem is the excision therapy takes way more training. So it comes down to like who is really serious about helping and who's money driven. Oh, I'm going to get in trouble for that statement. But I'm on the receiving end of this, so I'm upset and I'm going to say it.
No, I think
in Canada, I don't know how that works. It may be the same. In Ontario, OHIP may pay the same for. I don't really know how that works. It may. I suspect it might be similar.
And so tell me, okay, so then obviously it would be, I'm wondering about a diagnosis, which I understand is really hard to get. And this is where a lot of my clients struggle, is they come in and very few of them are saying, I have endometriosis, and I know that it's really hard to diagnose. So they feel so confused, and so they feel like they're not at the end. They don't have any type of resolution. They want a diagnosis. And so I try to talk to them about what that looks like, and why in some ways it doesn't change anything. But if you could speak a little bit to that. So usually to have a diagnosis, people would need to be going to this specialist, correct?
Not necessarily. You can get diagnosed by someone who's going to do the laparoscopy, but I made the mistake of not asking enough questions. I didn't know enough.
Yes.
And well, anyway, I mean, she couldn't even do any surgery at the time because it was just exploratory surgery. So I would say don't ever do that, because she found a lot of it, and then I had to go back again and get put under again. So where you're going with that is a laparoscopy. So making tiny incisions and then going in with a camera is the gold standard of being able to diagnose it.
And that's going to be done by the specialist, correct? Like, I just want people to understand.
Yes.
Family doctor.
It's got to be done by some specialist. It's not done by the GP.
Right, exactly.
But I would say I direct my patients to go straight to the actual endo specialist, because why mess around with someone who doesn't do excision to get, I mean, in Canada, we have to wait so long. So you might as well just wait for the right person.
Yes.
But some doctors say they can see it on MRI. Some say they can see it on ultrasound. In the book that I was reading, which I'll get to, the MD who wrote it with Amy Stein, who's a pelvic PT, she said that what she tests is the uterosacral ligament, which is a ligament that goes, so imagine this is the cervix. Your cervix isn't necessarily that long, but the uterosacral ligament goes around that, like right at the top where it meets the uterus, and attaches onto the sacrum. And one of those ligaments might be tight, so she checks internally, plus in those pouches between the bladder and the uterus. and the uterus and the rectum. So she'll manually check, which we as pelvic PTs can do. We can't really diagnose, obviously, anything, but it might give us a clue to say, I want you to see a specialist.
Okay.
Yeah.
But basically,
And then the history is a big
of
part
course,
of it.
like the history is a big thing, but to truly give you a black and white, yes, you have endometriosis, they basically have to go in laparoscopically and
Yeah.
excise some of the tissue.
Oh, they can see it.
Okay.
They'll be able to tell by looking at it. So it can be diagnosed just on vision without doing any excision. But why not treat it while you're there?
While you're there. So
Because what's the point of having the laparoscopy? So there are some people like me at this point. I had ablation therapy. I do have a son now, and I'm done with having kids. So it's not debilitating to me anymore. So I'm okay with not getting excision therapy. So you have to kind of weigh the pros and cons of going through that process. And I would say for adolescents, like their parents may not want them to go through the excision therapy at that age as well, right? So then maybe the idea for someone my age is an IUD if I still had pain. And then that age, more of the pill to manage the symptoms.
right.
But
So I was telling Jill before we started recording this, what I would love to do is make this into a 2-part series where we talk a little bit about kind of what Jill recommends for treatment for women in an ideal world. I would love first, Jill, talk a little bit about what tends to happen, when women are told that they have endometriosis, what is usually the course of treatment? I know we've touched on that, but
is this after or before laparoscopy?
Whatever, just like
So
people don't have that, right? And so I just want you to talk. I want you to guess what I'm getting at is talk a little bit about the birth control, the IUD, what they're told, pain meds. Like I just want you to talk about like what usually women are doing to manage it.
yeah, so a lot of times they will prescribe the pill, which I hated personally. I did not do well on it. It made me depressed, and I am not a depressed person.
Yeah.
So I didn't like the way I felt. I've tried a whole bunch of different kinds. It did manage the symptoms though. So, but since then, I've learned there's a lot of other things we can do to manage the symptoms that are way healthier to do anyway. So the pill is a viable option for younger people. The IUD, both of those, that and the IUD being the Mirena, which has progesterone. So it's more of a hormonal control. They're trying to lessen the estrogen. But if you're thinking of having kids or having trouble having kids, like I would go to the excision. I mean, I definitely would consider that. The specialists know what they're doing nowadays, and I don't know. But a lot of times they might put you on Lupron, which I am not a big fan of. I've been on that, and I do not like reading what I have read on it. And I think they give it away a little too quickly.
What are they trying to address with the Lupron?
I think they're trying to put you in like a medical menopause. They're trying to really halt everything, which I also don't love the idea of. I mean, these are my opinions, so let's take that with a grain of salt. But I'm sure I'm going to have a lot of MDs watching this going, "Rrr." Oh, what's that? Did you have something pop up?
Yeah.
Okay. Anyway, so usually they're trying to hormonally control it.
Okay.
Unless you get the excision therapy.
And then obviously, like I see a lot of women that are like, yeah, no, I take my naproxen for 1 or 2 days every single time I get my cycle. Like a lot of them are basically said, like, just use it. Use the medication to manage the pain when you have it, right?
Yeah, I think the key with naproxen is to get it before you start to get major pain, because once the prostaglandins are released, which gives you pain, it's almost like, and I bet you a lot of women have figured that out, like taking a naproxen when you've already got well into the pain. You might be able to take it like at the beginnings parts of this pain, but really, if you are regular, you could maybe, or start monitoring your cycle, and then take it a couple hours before you would notice that you would get the pain, and it'll probably be more effective
Right.
at managing the prostaglandin release.
Right. Okay, I want you to tell me a little bit about like how does once someone has endometriosis, does it progress?
Well, what they've seen in teens when they do um, laparoscopies versus older women is that they generally see a progression. And I would guess it's because it's estrogen dominant. So um, the more estrogen you have going on longer, the more, that's, it's not written in stone, but they have noticed that generally adolescents have lesser of a stage than older women. But it
Okay.
doesn't, the stage also doesn't indicate pain.
I was gonna say, talk about that. Talk about
Yeah.
how it is staged.
So stage one is the least amount of lesions. It's dependent on where it is and
Endometrial
how.
tissue. Endometrial tissue.
Endometrial tissue, yes. It depends on where it is and how much it is, and that's how it's sort of graded. So it goes from stage one to stage four. But people could be, sometimes, they might inadvertently be doing an appendectomy and then realize somebody has endometriosis all over the place, and they're like, did you have any symptoms? And they're like, no.
Yeah.
And so my educated guess on that has to do with central sensitization
Mhm.
and how much inflammatory response you're getting in your body. And I know that firsthand. I can tell you when I'm inflamed and when I'm not. And so I think that is the biggest clue, or the biggest difference between people who have a lot of pain with stage one and not much with stage four. I mean, it'd be an interesting study. I don't think it's ever been studied, but
So what I kind of get out of all of this, through my practice, but also in talking with you and hearing a little bit more about your story, is that there there's so many unknowns, like we kind of touched on at the beginning. It is very hard to diagnose, and there's so many different variations or places you can fit on the spectrum of the diagnosis and your symptoms, and that it's hard for women to find their way through this system. And I think we all know that. And I think women that have endometriosis, I always stumble on that word, the pronunciation of that word, but I think they all feel that. The
yeah.
biggest reason I wanted to have you here is not only to explain that so that people can be like, oh my gosh, that's me. Like that's totally me. But I also want you to kind of talk now, and I'm going to break this into two different sessions. And in the next session, I want to talk a little bit about kind of like what you've learned through your journey, what kinds of things you think women should be doing for themselves and how they can kind of advocate for themselves to direct themselves down the right path. But most importantly, I want you to just tell them a little bit about what they can do to manage this. And so let's go into that in this next session, and we'll end this part here. Is there anything else that you think I've missed, Jill, to just kind of talk about um, before we close here, like anything about the diagnosis or about what tends to happen? I mean, we
No,
can talk.
I think we did a good job of covering that. I'm just gonna look.
Okay, so I'm going to stop us here and then we'll resume the next part, okay?